Perfect.
Wholesome
Thank
platy.
you.
Good way
Thank
to
you.
start.
That is a good way to start.
Just any adjective and platy.
Yeah, pretty
I
much.
think it's a theme that we're going
You
for
guys
here.
have figured out the formula. Hey, we're getting adventurous now. I should say at the start, it has come to our attention that we managed to skip a week accidentally. And so last week we kind of covered a bunch of stuff from week 3 and week 4. Whereas usually we were having things sort of staggered before that, where we would do like this week should have been week 4 content, but because we covered most of week 4 last week instead, we are covering week 5 stuff this week. So we'll probably just stick with the current schedule, if anything, because it means that like by the end of term, into semester, you guys will actually have quizzes and everything, because otherwise we'd be sort of dashing at the end. And we will probably try and integrate questions from the topics that we missed, if any, because I think we didn't miss very much, but the ones that we did miss, we'll try and get them up as soon as possible. And I know some of you might be waiting on the jaundice video, so we'll also be trying to get that up as soon as possible. Ideally, tonight or tomorrow night. We'll see how we go. I think the sound has stopped for some reason.
Oh, did it?
Yeah.
I think it's because I changed tabs. Oh, there we go.
There we go. It's back.
Yeah.
There we go. Perfect. I think maybe kick off. Oh.
Yeah. How many people? So we've got about 4 or 5 people here. So I might get started, and then anyone else who joins, just make sure to put in the number, and you can join whenever.
Yeah, exactly. Just make sure it stays open. Easy.
Yeah.
Perfect.
All right. Some anatomy. Which of the following is not at the level of a normal constriction in the esophagus? Oh, amazing. That was really fast. So really, really well done. Does anyone want to just unmute and let me know what that answer should actually be? What cartilage are we thinking of instead of the thyroid cartilage? Yeah, fantastic. Everyone's coming out with cricoid cartilage. You will cover the cartilages in the neck region, obviously a bit more in head and neck in semester 2. But when it comes to these normal constrictions, there's a really easy way to remember it, which is just A, B, C, D. So obviously A is arch of the aorta, B is the bronchus, in specifically the left one. D would be the diaphragmatic hiatus, and C is the cricoid. So even if you don't know specifically what all of those are, as long as you can remember them at this point in time, that's good. And it's also just useful to understand the idea of like physiological constrictions, because you will cover a similar thing when it comes to the ureters. Those are just places where things can get stuck if you have some sort of obstruction. So it's a good idea to clinically keep that in mind. But well done, everyone. All right, let's go to the second question. Which of the following is true of the duodenum? It's a bit of a tricky one. All right, so we've got a bit of a mix here. The answer here is actually blue, as you can tell. So I'll go through each of these in turn. So when it comes to red, I think no one picked that, but remember that the first part is the only part that's intraperitoneal. The rest of the duodenum, so everything except the first part, is going to be retroperitoneal. So that's why that's wrong. The second part of the duodenum is where the common bile duct will actually join in at the ampulla of Vater. So that one is actually correct. The third one, so the third part is directly vertically positioned. This one's a bit mean, but if you actually have a look at a diagram of the duodenum, you'll notice that this is not actually the third part, or at least the third part is not the one that's vertically positioned. And they all have different names, like obviously first, second, third, fourth, but you've got descending parts, then you've got horizontal, then it descends and it goes horizontal again. It's not that high yield, but I thought I'd include it there just in case you were interested in figuring out what each of those terms means. And then obviously for the fourth part of the duodenum, it doesn't connect with the ileum, it connects with the jejunum for the small intestines. I've got a question in the chat, which is, doesn't it connect to the hepatopancreatic duct? That's actually a good point. So yes, you're right. Technically, hepatopancreatic duct would be the joining of the common bile duct plus the pancreatic duct. But I feel like technically this is still true, right? You've got the common bile duct eventually connecting to the second part of the duodenum. But you're like what this is showing me, the fact that you've identified this is that you're very much switched on. So that's a really good point. If it comes down to semantics, hepatopancreatic should be the correct answer. But in this case, the other options are all incorrect. All right. Let's go to the third question. Which of the following is true of the large intestines? Sweet, everyone's picked blue. So yes, the tinea coli, they're the 3 longitudinal muscles, and it kind of links up with the yellow point, which is the haustrations. So those tinea coli, when they contract, they form the haustrations that obviously help propel fluid and your feces through the large intestines, but it also is a really easy way to tell the difference between the small intestines and large intestines on an abdominal x-ray, which is kind of the main point of this question. So remember that haustrations are non-circumferential. Unlike the plicae circularis? Yeah, plicae circularis in the small intestines, which, as the name suggests, actually goes around the entirety of the circumference of those small intestines. And of course, the small intestines are central, whereas the large intestines would be more peripheral, which is why green is incorrect. And then finally, the splenic flexure, as most of you have identified, is actually on the left-hand side. The hepatic flexure would be on the right-hand side. So well done. Okay, fourth question. A neoplastic growth found below the dentate line would be expected to, which of the following? Oh, okay, we've got a couple of mixed responses, and I suspect that's because this question is a bit long, so people may have just selected something, which is fair enough. And there wasn't that much time to actually do the question. But the point of this one is to just go over the really important bits that you need to know about the dentate line, or the pectinate line, as some textbooks call it. Remember that it is of embryological significance because it's the connection between the ectoderm and the endoderm. So endoderm on the inside and then ectoderm on the outside. That's important because that tells us that blue is wrong, because it should be in the ectoderm on the outside because it's below the line. When it comes to the other ones, we're thinking about the neurovasculature that's actually going to be innervating or supplying or draining the specific sections. So red is wrong because above the dentate line is where you have the dull diffuse pain. That's where you have visceral sensory innervation. It's usually like sympathetic, parasympathetic stuff. Whereas below the dentate line is where you have the somatic sensory innervation, which is why when you get hemorrhoids below the dentate line, those tend to be way more painful and kind of like localized than hemorrhoids that are above the dentate line. In fact, hemorrhoids that are above the dentate line, you tend to feel no pain. You just feel like there's a mass there that you're trying to get rid of when you go to the toilet, but you can't quite because obviously it's not feces. So that's why red is incorrect. Yellow is incorrect because it doesn't drain into the internal iliac lymph nodes first. I believe it actually drains into the superficial inguinal lymph nodes first before then draining deeper. So that's the key distinction to make there with the lymph nodes and metastatic spread. With the veins, this one is actually correct. So it actually first drains into the portal venous system. If you look at the venous drainage of the different parts of the anus and the rectum, you will see that the bottom regions of the anus get drained into the portal system, whereas regions that are higher up, they get drained directly into the IVC via systemic venous drainage. So it's a bit of a tricky question, and it really is, but I would recommend just having a look at this question afterwards. So maybe screenshot this and have a diagram up that shows the distinction between above dentate and below dentate line, because it's a very, very examinable piece of information. Oh, yes. And neoplasm was a fancy way of saying tumor. Yeah, good point. All right. Does cholestyramine increase or decrease the activity of 7-alpha hydroxylase?
Nice. Okay. So I think I wrote this one. Yeah, you guys have all got it. Basically, the upshot is that 7-alpha hydroxylase is the sort of rate limiting step when we go from cholesterol into the precursors for bile salts. And basically, we're sort of opening the faucet a little bit wider when we use cholestyramine. And the idea is to then pull more cholesterol out of the serum, out of your circulation, into your bile. And generally, we don't usually have too many problems with too much bile. Most of your problems occur when you have too little bile. And so we don't worry too much about that. It's generally a good therapy for cholesterol levels.
All right, awesome. Let's do the next one. Which of the following refers to inflammation of the biliary tree? So some good and confusing terminology to get used to.
Interesting. Okay, I did trip up a couple of you guys. So just running through these really quick. Cholelithiasis and choledocholithiasis are sort of a little bit easier to understand because they are basically just talking about the location of a gallstone. So both of them, you can tell by lith. Like your lith is just like Latin for rock. I think it's Latin, might be Greek. But you'll see like urolith for kidney stones, and then cholelith for gallstones. Okay, or fecalith for, you get the idea. But those gallstones, if they're in the gallbladder, they're going to be in the they're going to be called cholelithiasis. If they then leave the gallbladder and they go down that into that colon bile duct, we call it choledocholithiasis. Okay. And then cholangitis is a pretty normal complication of choledocholithiasis because then the bile duct becomes inflamed around the stone. But it can also happen just inflammatorily, and then we still get symptoms of jaundice because the inflammation is enough to close it. So we can get cholangitis with or without choledocholithiasis. Cholecystitis is a complication of cholelithiasis, i.e. we're still hanging out in the gallbladder, and it just means, well, cholecyst, gallbladder, itis, inflammation of the gallbladder. So you'll see a lot of patients with acute cholecystitis in hospital on your like gastric surgery lists, and they'll come in for a cholecystectomy where we take out the gallbladder.
Yeah, awesome. I'd recommend if you're still confused by all of these, just draw a picture of what all of them looks like, because they obviously all have similar, first four letters, but it's the ending that makes the difference. And if you understand, as James was saying, like what lith means, what itis means, things like that, it makes this a lot easier to understand. Okay, next question. What is the final form of most bile pigments? What do they eventually get converted into?
Interesting. Okay. So, yeah, maybe this one's a bit confusing. So basically, we have a pathway here where we start with heme, which is your precursor to a whole bunch of useful stuff in your body. And in the liver, that gets turned into biliverdin. I'm glad none of you guys picked that. So that's your intermediate stage. That's the green one. And then it gets turned into bilirubin, okay, which is your main actual bile pigment. So bilirubin will then enter your well, it'll be in your bile, right? And most of that will then sort of stay in your intestines once it goes in as part of the bile, and it'll become excreted as stercobilin. And as we talked about, stercobilin is what gives you your poo that sort of brown color. Okay, urobilin is a little bit of recycling, so it's stuff that gets reabsorbed and then eventually sent to the kidney, and then it comes out in your urine. Yeah, and so maybe it was a bit confusing when we talked about, like, when I'm asking what the final form of bile pigments is. So while it certainly it leaves the liver as bilirubin, it leaves the body, or it ends up like the only thing it doesn't get converted out of is stercobilin and urobilin to a lesser extent, but that's why we said most. So stercobilin is the end of the line, whereas bilirubin, it could go in all sorts of directions, including being recycled.
All right, thanks, James. We'll now move on to, I think, a little bit of clinical skills. Yeah, there we go. I've most definitely spelled that wrong, by the way. I think there's a H in Murky's lines, but I think you should still be able to answer the question. Yeah, cool. I think I've kind of confused or trapped a couple of people with red. So the important thing with this question is to understand what all the peripheral stigmata of some of the more like central organ damage or central organ conditions would be. So instead of thinking about having sort of like a list of signs that you want to run through, it can be a good idea to group them in terms of the organs that are most likely to be the root cause of that particular sign. So in this case, Merkey's lines, I think that's how you pronounce them. You see them on the fingernails, and they generally don't go. So the vertical ones, they're actually different. They're leukonychia. Merkey's lines, actually, if you have a search online for a picture of them, they're actually transverse lines. However, the net sort of understanding is that Merkey's lines and leukonychia, they both indicate some form of hypoalbuminemia, low albumin in the blood. There's a term for that. I would recommend you search that up. I'll type it in the chat. I can't pronounce it today. So that's why red is incorrect. And that's also why yellow is incorrect. That one says hyper instead of hypo. Now, green is incorrect because can anyone tell me what would be the actual sign on the nails that you would see in a person with iron deficiency? What is that called? Does anyone know what that would look like? Yeah, so someone said spoon nails. So yeah, you got your spoon-shaped nails or koilonychia. That's the specific thing that you would see in a patient with iron deficiency. And then you would think, oh, potentially they have anemia, and then you do investigations for that. But in this case, because we know it's a low albumin level in the plasma, we're thinking maybe there's a problem with liver function. Not necessarily, but there could be. So it can warrant further investigation there. But that's why the other options are all incorrect. Well done. Okay. Which of the following findings is characteristic of severe liver disease? So we're sticking with the liver still. For all this, try and think of either the underlying pathology or what term you would use to describe that particular sign. All right, cool. So yes, I like that a lot of people have picked both red and blue because they do sort of indicate some sort of liver, like could potentially indicate some sort of liver pathology. But in this case, I'm trying to go at something that's a bit more severe. So although you are like on the right track, red is more correct because the rhythmic flapping, when the hands are cocked back, arms are extended. Does anyone know what's that called when we're thinking about some sort of liver pathology? There's a really long, yeah, so it can be called asterixis. That's another term for the sign, but what could the cause be? Why am I getting a rhythmic flapping in my hands when I have liver disease? What's the connection? So it's not quite CO2 retention. So that you're thinking really along the lines of the RESP system. So you're absolutely right. When you have a patient with CO2 retention and you ask them to do this, they'll have the same sign. But in the case of severe liver disease, it's actually called hepatic encephalopathy. And the reason why that happens is because the liver is not able to actually get rid of all the toxins from the blood. That's one of the jobs that those hepatocytes do because the liver is damaged. So all those toxins remain in the blood, they remain in the plasma. And one of the places they love to go is across the blood-brain barrier towards the brain. That causes the encephalopathy, which is the reason why you get these neurological manifestations. Now, I'm not sure if that's something you've covered at this stage because I'm not sure if it's covered in clinical skills or anatomy, but it's going to be something that you will definitely cover when you get to the accessory organs of the GI system, which I've made a video on that should be available on YouTube. But that's a really, really good one to just keep in mind. With the redness of the palmar creases, Dupuytren contractures, those are pretty typical signs of someone who is a chronic alcoholic or is suffering from alcohol abuse disorder, which again can lead to severe liver disease, which is why I'm not going to say it's completely wrong. There's just like the red kind of indicates something a bit more extreme. What is the dark velvety patch in the armpit region? I think this is something you probably would have covered in Clin Skills. What is that called? Yeah, awesome. Acanthosis nigricans. So that's a sign of insulin resistance, typically in diabetes. And then tendon xanthomata, xantholesma around the eyelids, that's your cholesterol deposits, which you need to look out for in all exams. Well done. All right. What sign is matched correctly with the underlying pathology? Awesome. I've got a good spread. This is a bit of a mean question as well. Like there's a couple of words here and there that are a bit off. So with Kaiser-Fleischer rings, it's actually Wilson's disease, not Winston's disease. Wilson's disease is when you get copper deposition in all different parts of your body, and you get it around the pupils. So you get those characteristic kind of like greenish, bluish tinge around the pupils, which is a sign you get on the face. Gray Turner's sign is one where you turn the patient on their side. You can see the bruising on the side of their abdomen, which is actually an indication of retroperitoneal hemorrhage, so all the way at the back. Courvoisier's sign, this one is actually interesting because you get an enlarged gallbladder, which you can actually palpate or at least feel, but it's not actually painful. And so that indicates that it's not a gallbladder that is affected with inflammation. It's just that there's something compressing the outflow of bile from the gallbladder. And the most characteristic or pathognomonic thing you need to know that can do that, of course, there's multiple causes, is ahead of the pancreas cancer because of the proximity of that to the biliary tree. And then Murphy's sign is not acute appendicitis, that's acute cholecystitis. So you get, you press down on the region of the gallbladder, and what happens is when the patient takes a deep inspiration, they kind of just suddenly stop their breath because it causes them a lot of pain when they inspire. So good ones all these signs are really good ones to keep in mind, but I would recommend just understanding the distinction between Murphy's and Courvoisier's sign as the most important takeaway from this. Okay. Which of the following statements is most correct? Yeah, cool. So I'll go through each of these again. Enlarged spleen, it does expand inferomedially. So it goes, in other words, fancy way of saying it goes diagonally. But the thing is, it doesn't go to the left lower quadrant. And if you think about it, that makes sense because the spleen is already on the left-hand side. If it goes diagonally, it should end up going towards the right lower quadrant, which is why that one is wrong. Bloodable kidneys are not always abnormal. Whenever you see a question that says always, that's probably going to be wrong. One instance that I can think of is if you have a really thin person. So you might be able to feel their kidneys pretty nicely, even though they don't have any organomegaly with the kidneys. Abdominal rigidity is not voluntary. Abdominal guarding is actually the voluntary response. So the patient knows that when you press on their abdomen in this spot, it's going to cause them pain. So they start to physically tense up their muscles to prevent you from pushing down on it. Whereas abdominal rigidity is something that they're not in control of. And that's because of the peritonitis that's causing the inflammation of the peritoneum, and then the muscles start to spasm. The green is correct because typically when you hear the terms expansile pulsatile mass, that's quite pathognomonic, especially if it's in the umbilical region for an abdominal aortic aneurysm. In other words, a dilated aortic abdominal aorta. For multiple reasons, which is not going to be covered this year, but it's just a good idea to know that if you feel it, that is, it's quite specific for AAAs. Awesome. As always, if you have any questions at all, feel free to post them in the chat, or if anything I'm saying doesn't make sense. Which of the following is true regarding shifting dullness? Yeah, awesome. You guys are all on top of this. So remember with shifting dullness, you need to percuss twice, right? You've got the normal percussion. So you go from one side of the abdomen to the other. If you hit a point that is dull, then that might be a place where there's fluid. It could be other things, which is why you do this test to confirm if it's fluid or not. What you get the patient to do is roll onto their side, wait about 20 to 30 seconds so that the fluid can settle to the other side of the abdomen due to gravity. And then you repercuss that spot. And if it goes from dull to resonant, in other words, the fluid has moved away, so now there's just normal air there, then you know that that originally was ascites or fluid. If it just stays dull, then it might be something else that's kind of localized or trapped there, like a consolidation or something. Negative shifting dullness is not for ascites, that would be positive. And you can't percuss immediately because, as I said, you need to wait about 30 seconds. Awesome work. Okay, and finally, which of the following is not a manifestation of portal hypertension? Awesome. So I feel like this is probably not, again, not something you would have really like covered in detail. So you may not have had a proper like anatomy session on portal hypertension so far, which is fine because in clinical skills, I think you still cover one or two or three of the signs that you might see on examination. So you might be able to rule out a couple of these, which I can see you've done. One is caput medusae, which is kind of like the little red spot that you get around the umbilicus, and then it's got these spidery veins coming off it. And that's because of, remember, all of these manifestations are generally because you've got the portal venous system and the systemic venous system, you've got the anastomoses. And because the portal system is all clogged up because of the hypertension, you get backflow into those anastomoses, and they either enlarge, called varices, or they can rupture, which can cause quite a lot of bleeding. So caput medusae would be for the varices that are kind of around the umbilicus. Hematemesis is a pretty big red flag for esophageal varices, for the anastomosis in that region. Splenomegaly, again, similar thing. You've got the backflow of blood that can then clog up the spleen from the splenic vein. Hemorrhoids is actually an interesting one. So hemorrhoids is actually just like it gets interchanged with anorectal varices, but they're not actually the same thing. So anorectal varices is quite specific for portal hypertension, but hemorrhoids is actually just a prolapse of some of the venous plexuses that are inside the rectum. So they're actually not the same thing. And this question is just to highlight that difference. So if you're still confused, I would recommend searching up hemorrhoids versus anorectal varices, because they're not the same. And if you get asked in an exam for portal hypertension, it will not be hemorrhoids. Okay. Awesome. We now move on to a little bit of pharmacology.
All right, I'll take you all through these questions now. So this is a classic question they can ask you in the exam by H. pylori and treatment of it. All right, perfect. So everyone's got it correct. So you do need a PPI, amoxicillin, and clarithromycin. I'll go through sort of why we take these drugs in a H. pylori infection. The first thing you've got to know is that with H. pylori, the risk is of gastric ulcers. And in that situation, you want to reduce the acid production so that you're reducing the damage to those ulcers. So one way you can reduce the acid production is using proton pump inhibitors. A good example of that is esomeprazole. And then when it comes to actually combating the microbial agent, so the H. pylori, you want to use some sort of antibiotic because it's a bacteria. And so you're going to use, in this case, two antibiotics, because one won't do the job because it won't cover the sensitivities that the bacteria might have. So usually use two, just in case the bacteria is resistant to one. And that way you have a higher chance of wiping out completely. And so that's why the answer that's given there is the most effective. A good way of remembering it can be using the mnemonic PAC or CAP, however you want to put it. As long as you remember it's PPI, amoxicillin, and clarithromycin. Could you open the media, Jainam?
I don't think I can actually zoom into it.
That's fine.
Yeah, it'll only be once the question is done, but hopefully that's legible.
All right, perfect. Let's have a talk about this question as well. The first thing that I guess is involved in this question is figuring out what what Will has. Could you open the media for this one, for the question? Yeah, perfect. So we see a person who's experiencing acid at the back of their throat. And if you recall back to, it might have been clinical skills when we talked about the gastrointestinal systems examination and systems review. We also talked about GORD, or gastroesophageal reflux disease, where because of the acid reflux, you get a feeling of acid at the back of your throat because the acid is going up your esophagus into your throat. And so that's what he's experiencing here is GORD. And you're also having intense epigastric pain, and that too with bouts of vomiting with coffee ground appearance. And that's sort of pathognomonic again for peptic ulcers, because this coffee ground appearance comes from the fact that you have a peptic ulcer in the stomach that's leaking out blood, and that blood is being vomited up. But because the blood is digested in the stomach acid, it's got more of a browner or darker coffee ground appearance as opposed to just a fresh blood appearance. And the pain comes from the ulcer being damaged by the acid in the stomach. So your primary goal is going to be to reduce the acid production so that your ulcer can have a better chance of healing. And there's a couple of drugs that are given there. So esomeprazole is one of the most effective ways of sort of treating this, because a PPI is really, really effective at reducing acid production. Bismuth, the way that works is it sort of covers and protects the ulcers from the surrounding acid so that you can prevent further damage to the ulcer, but it doesn't resolve the actual acid overproduction. So your person is going to have peptic ulcers being managed, but the gourd where you have the acid reflux into the esophagus, that's not going to be managed by the bismuth, if that makes sense. And the same thing with rintidine is that it's not as effective because it's going to, I guess it's not going to be as effective as a PPI when it comes to reducing acid production. The other thing I want to mention here as well, which I might not have mentioned in the slides, is that with bismuth, one of the undesirable side effects is you get black stools, and you also have neuro and nephrotoxicity. Yeah, that's basically it. If you have any questions or concerns, if I'm speaking too fast as well, let me know in the chat and I'll sort of slow down and go through the questions in more detail.
You got a clinical case here.
All right, so a tricky question. So I'll sort of try and explain it because I think it was worded a bit weirdly as well. So the question says severe constipation. So this person is having some sort of an obstruction which is stopping them from defecating. The fecal occult test is positive, which means that there's some sort of a fecal occult test, by the way, is where I believe the way it works is you give a stool sample to a lab and they look for bleeds inside the stool. And blood can be a sign of cancer that's bleeding into your gut. And so the fecal occult test was positive, which is a screening test for bowel cancer. And sure enough, when they did the colonoscopy, they definitively diagnosed bowel cancer. I'm assuming with a biopsy here. But the main thing overall is that the bowel cancer is the cause of the obstruction, which is causing the constipation. So you have a tumor, a growth in your bowels, which is obstructing the flow of feces. Now, with drugs like Senna, Metamucil, Lactulose, they're all really good for constipation because, again, they're laxatives and they're going to make your gut try and push out the obstruction. The issue is the obstruction we have here is an overgrowth of the gut wall itself. It's a tumor, right? So no matter how much you use laxative wise, it's not going to be able to push out something which is literally part of the gut wall. That's why using things like Senna and Metamucil and Lactulose, all those laxatives, isn't actually going to push out the obstruction. It'll likely just cause more and more of the feces to build up behind it as it tries to move out and cause greater fecal impaction. And if that grows really big, it can also actually perforate the bowel as well. That's why these options are not going to be ideal. Instead, your best go-to option in this case might be Docusate, which, if you remember from the lecture, is a stool softener. It works in a different way by sort of causing the water lining the gut walls to collapse onto the stool, soften it, and therefore let it come out. It's got a weaker laxative effect, but it's going to be safer in this case with a natural obstruction like a bowel cancer. Another thing that I want to mention here as well is that a long-term side effect of Senna that we mentioned in the lecture as well is that because it's an active laxative, it can result in lazy bowel because I guess your gut becomes over-dependent on stimulation from Senna, and so it becomes less responsive to natural stimulatory signals. Yep.
Yeah, so this is not, just for anyone wondering, this is not like a random question or anything. This has come up in previous exams. So it's just a good idea to understand that if you have an obstruction, it's not the best idea to try and push more feces against it because you're just going to end up causing an even bigger obstruction for this patient. Okay. Severe nausea and vomiting on starting chemo. What is a 5-HT receptor blocker that the doctor could prescribe?
All right, we've got two answers here. One is ondansetron and one is promethazine. So again, all the drugs here are actually anti-emetic / anti-nausea, anti-vomiting drugs. But what makes this answer, specifically the blue one or ondansetron, is that it says it's a 5-HT, also known as serotonin, receptor blocker. And the only drug that qualifies as that is ondansetron. Metoclopramide is a dopamine 2 receptor antagonist. Hyoscine is an anti-muscarinic, and promethazine is a histamine 2 receptor antagonist. And in general, you have to know that ondansetron is sort of the best choice from the lot when it comes to chemotherapy-induced nausea and vomiting. Yep, and that's the reason why what blue is the answer there.
All right. So I think for the next couple of questions, guys, if you want to have like calculators handy, it's not like a really like complex question, so you don't need a scientific calculator or anything, but even just like Google calculator should be enough. We're going to be going through a couple of specificity, sensitivity, that kind of thing. So just keep that in mind. Okay, here we go. Let's do some maths. Choose the closest specificity for the following data. Remember, what does specificity mean? Oh, awesome. Great work, guys. So remember, specificity is your true negative number. So negative test as well as no disease. So that's 34 divided by people who actually have no disease, right? So 34 divided by 40, which should give you approximately 85%. Okay, well done. Now to test your knowledge a little bit further, here's another confusing term to have a go at. Choose the closest positive predictive value. Yeah, great work. So the really only the difference between like positive predictive, negative predictive, and then sensitivity and specificity is with sensitivity, specificity, you're working with these numbers as your denominators, so the ones on the right hand side. Whereas with PPV and NPV, you're kind of working with these bottom numbers as your denominators. The numerator tends to be like same. Okay, so if you want to think about it like that, that makes it a bit easier to remember. But I would also try and understand what each of those means, just in case you get a question asking for, like, what is the definition of PPV? Why do we care? And that kind of thing. But it looks like you guys are all on top of this, so well done. I think the people who picked 95, it might just be a slight rounding error. Let me know if it's actually an incorrect question, and I can check that. I can fact check that, but I think it might just be a rounding error. Yeah, the table switched, I think. Okay, I think that's just to trick you a little bit, but they can do that in the exam, so keep that in mind. Okay. Last question, you're almost there. Well done for sticking through so far. Which of the following is or are inherent to the test and not dependent on the population being tested? Oh, lovely. Yeah, so this is just kind of facts. So sensitivity, specificity, they will never change. And I think just an easy way to remember this is that you'll go through so many classes in your uni life, and they will say the sensitivity of breast screen is this, specificity of breast screen is this. No one says sensitivity of breast screen in a population with a huge number of people with breast cancer is this, and then compared to low prevalence of breast cancer. No one ever says that. Whereas PPV and NPV, maybe you've never heard of them, but just remember they're the opposite, right? So they depend on the actual prevalence or incidence of that particular condition in the population. Don't ask me why, it's a bunch of math stuff, and I'm sure there's someone here who can explain it, but just remember that that's the distinction, okay? Awesome, well done. And that's pretty much it for the questions. Here's the podium. Well done to everyone who came today. I know that we had a couple of really, really tricky questions, and you guys mastered pretty much all of them, so really, really well done. And especially well done to Onisan Platy. You've done really, really well. 12 out of 20 questions, that's really good. So you should be proud of yourself and everyone else as well. You've got pretty much more than 50% of the questions right, which is really good. I will just say that, just to reassure you guys a little bit more, we do try to make these questions a little bit more difficult. Yes, they're more high yield, but we try to also challenge you a little bit with these sessions. So don't be scared if there's some things here which take a lot of time for you to read the question in full and then figure out your differentials and then figure out the answer. That's not going to happen in the actual exam. You'll have a bit more time to work with. And generally speaking, if you know the answer, you know the answer. If you don't know the answer, that's fine. You will learn something anyways. And that's the point of these quizzes. So pat on the back for all of you guys. If you do have any questions at all, please feel free to stick around. I'll stop the recording.